Good evening, ladies and gentlemen, and welcome to this first 2021 Theoxane Academy Geneva live session. We are broadcasting live from the Geneva Academy tonight, and we will be as well broadcasting from London. We're very happy to welcome you here tonight. We will be talking tonight about temples, beautiful temples, natural temples, and also mid-face enhancement. And to talk about it, we have with us tonight two experts in the field. The first one is based in London. Let me introduce him to you. This is the Dr. Benji Dillon. He's a cosmetic surgeon from London. And he will be introducing the topic with answering and talking about natural and dynamic treatments within temples and mid-face areas. Of course, he will stay with us during the whole session, so he'll be able to answer your questions, since we know you are very keen on asking questions, and we are very happy about that, so keep on doing it. Good evening, Dr. Dillon. Can you hear us?
Good evening. Yes, can you hear me?
Yes, we can hear you. Welcome. We're very happy to have you with us tonight.
Thank you very much, Melanie. Thank you very much for having me. It's such a pleasure to be here.
All right. Perfect. Perfect. Let me introduce you to the next guest tonight, which is one of our famous experts. Since you've been following us from the beginning, you know him for sure. This is Dr. Patrick Trevidic. He's a plastic, aesthetic, and reconstructive surgeon from Paris. But tonight, he'll be with us here in Geneva and injecting live from Geneva with two patients. Hello and good evening, Dr. Trevidic.
Good evening. I'm very pleased to be there and hope you will enjoy, what we will do tonight. We are very open mind, so share with us, your questions. That's very important. And we will try to show you step by step, how we do and we perform this injection.
We're looking forward to it, and we'll move on right now to the start of this session, and this is the introduction talk, and this talk is going to be made by Dr. Dillon. Back to you.
Thank you, Melanie. Thank you very much for having me. Absolute pleasure to be here with Dr. Trevidic. So for the first 10 minutes, as an introduction to Dr. Trevidic's live injecting videos, I'd love to talk you through the importance of natural outcomes and what they actually mean, particularly for the temple and mid-face in terms of natural dynamic enhancements. So what do we mean by natural? Natural is a very subjective word and one that's often thrown about a lot of the time. And we've got to give it some degree of definition. For me, natural, and this is based on published literature, is an important aspect of non-verbal communication and signal characteristics, i.e. what are other people reading off our face non-verbally that projects who we are and how we feel. And it's described as avoiding looking unrecognizable and maintaining self-identity. Now, this is really key because not only is it other people judging us on how we look, but actually what we see from this is we judge ourselves on how we look. If we look natural, this comes across in our personality. And here I've just placed a graph showing you my thoughts on how age-related changes interact with how we feel as individuals. And we can see from some data that after 50 years old, more than 90% of women are concerned with at least one aesthetic issue. And if we take these two red dots in and around the age of 50 years old, when perimenopausal symptoms may start to impact on a female's face, their age-related changes, and also how they feel emotionally, what we're trying to do is really just move them up the graph. We want to take a patient maybe just over 50 years old, down in terms of improving their age-related changes, and also making them feel a bit better, rather than necessarily look different. And then what do we mean by facial dynamism? Now, this is dynamics, facial dynamics and facial animation are such key words. And it's Dr. Trevidic that really brought this into our literature through his excellent cadaveric dissection, showing us how these different layers move and how they act. And what this means is natural movement of the face, which is essential to natural outcomes. Now, for me, the key here is assessing in repose is not sufficient. We need to start assessing our patients in animation. For far too long, and I've been guilty of this, we've been to meetings and we've been to congresses where we've seen beautiful before and afters of patients put side by side, but they're often in repose. But what does that patient look like when they animate? What does it look like when they smile? Is the volumizing product in the right place? Are there any animation deformities? And has the right product actually been chosen? So facial expressiveness significantly impacts on personality processes, i.e. again, how we feel about ourselves, as well as the emotional reaction in others. So what do others think of us? Because it's not enough just looking great, not smiling or not animating. We need to look great and look natural when we move and animate and express ourselves. So to achieve natural facial dynamism, we must therefore understand 3 key elements. Number 1 is facial aging. Facial aging and understanding how the face ages is so vital for us to be able to deliver natural outcomes. We need to understand how each layer here represented, the skin, the superficial fat, the muscle, the deep fat, and the bone change over time, and be able to read a face. So for example, we all know about this inverted triangle and the bottoming out factors and features we see with the way particularly women age. We need to understand why this is happening. With this, we get clarity and understanding of what we can do. We also need to understand what is beautiful. What is the right aesthetic result we should be aiming for? And therefore, what are the proportions we need to be maintaining to achieve natural outcomes? And this will differ with gender and ethnicity. And then finally, the actual fundamentals to all of this, which is ATP, anatomy, technique, and product. And as we go through today, and Dr. Trevodich will be injecting and talking through his patients, I cannot stress the importance for all of you to think about what he's looking at and how he's looking at. I know he's going to be talking about this and referring to each one of these 3 points, but we need to understand, again, the layers and how they differ throughout the face. So natural looking outcomes in the temple, what are they, and why does temporal hollowing occur? It's an aging feature, particularly in the female face, but it cannot be looked at in isolation. For far too often, we often just look at one area of the face. We need to look at the entirety of the face. The anatomy of the temporal fossa, as I'll be going through in just a few short slides, must be appreciated in terms of its layers and the target layer where we need to place our product, the vasculature and the associated dangers, and very importantly, the surface anatomy. We need to understand our technique. It must be appreciated the differences between the deep, i.e. gunshot technique onto the periosteum, and the superficial or subcutaneous technique. And then finally, product. Choosing the correct product is dependent on the patient, the anatomy, and also your technique. There's the choice here of Ultra Deep and RHA4, my preferred products within this area, but some people may consider even a product like RHA2 superficially. But I know most of the time we are focusing on the use of Ultra Deep and RHA4 in this indication in this area. Now, the risks of overfilling the temple is very much a balance with the mid-face. You just look at this picture I've just picked up off the internet of a UK-based celebrity. And you can see an over-exaggerated mid-face has made her look like she's got temporal hollowing. Now, the risk if you fill this temporal hollow, you could risk changing significantly more, not that they haven't been changed already, the proportions of the face. And if we think about the anatomy of this area, let's start with the bone, the deepest layer here. We have to appreciate that the temporal hollow is in a vicinity that's a conjunction of a few different bones of the skull. The temporal hollow itself is bounded by the frontal bone, the zygomatic bone, the zygomatic arch laterally. And we need to appreciate the position of the pterion in relation to this, which is a very weak structure. We also need to understand the layers of the temple. There are effectively and essentially 5 key layers we need to appreciate. Number 1 is skin and subcutaneous or superficial temporal fat. Number 2, the temporoparietal fascia. Often this is where the superficial temporal artery will run. Now, the superficial temporal artery is a branch of the external carotid, and you can feel this as it traverses up the face at the tragus, and you'll feel a pulsation here. About 5 centimeters above the zygomatic arch, it branches into a posterior and a frontal branch. And most of the time, and we've got Patrick Trevodich, a world-class anatomist, who will talk about why the frontal branch is one we truly have to consider in terms of the injection anatomy we're focusing on for the temple. Next, we have the loose areolar tissue. Underneath this, the muscle and temporalis fascia. When we talk about muscle, we talk about temporalis. And then finally, bone. And if we look at some dissections here that Dr. Trevodich has provided, we can look at, if we're focusing down here, and I've placed here my purple dot, which is approximately the area of treatment or the area of injection in the temple, which is often about 1 centimeter up the superior temporal ridge and 1 centimeter back on average if using the gunshot technique. Now you can see here that the skin and the superficial temporal fat have been reflected or dissected off. You can see here temporalis with the superficial temporal fascia and the frontal branch of the superficial temporal artery. We can see the location and the proximity to where we need to treat. We go a little bit deeper and we reflect back even more. We go down and we can see here, number 5 is the deep temporal fascia, and overlying this again is the frontal branch of the superficial temporal artery. And again, look at the proximity of where we need to go to treat the temple. Now, the temple is often an area that I feel a lot of people are fearful of treating off. There are no safe areas in the face, but if we understand the anatomy here, which Dr. Trevodich will go through again on the models, we can appreciate the dangers and therefore treat in a safe manner using the right techniques. And if we then move on to the midface, now natural looking outcomes in the midface and natural dynamics is often, I think, a very misunderstood area and isn't always performed to the best of our abilities. But to achieve natural outcomes, we have to first maintain and respect facial proportions. We've got to be conscious of the volume and product used, and also examine in repose and animation. This is where I think a lot of people fall down a very dark hole, that we forget to ask the patient to smile and look at the movement of the anterior medial superficial fat and look at the superior displacement of that fat and how it impacts the orbit. So examine the face in animation. The anatomy, we've got to understand the different layers of the anatomy, but very specifically, we've got to appreciate the difference between the fat compartments. The superficial fat, as you can see here, is a dynamic facial fat compartment. It moves with the face. So immediately, if this is an area we feel we need to treat, we've got to be choosing the right product to treat this area. And then finally, the deep static compartments. This is where we often lose volume and therefore choosing a right product. And it's really here in the midface, we truly consider sandwich techniques. What is the right product for the deep compartment? And do we need a slightly softer product, more gentle product for the superficial compartments that still allows dynamic outcomes? We then have to understand the right techniques to use. Now, technique here is one of the most interesting points of discussion, particularly in the midface, whether someone uses a needle or cannula. And I feel here is, as long as you understand, appreciate the anatomy, you've got to use the right technique that works for you to achieve safe and good outcomes. And then finally, yes, Ultra Deep and RHA4 are beautiful products using sandwich techniques in this area, but I have to admit, I do often use 3 and sometimes 2 superficially, depending on the skin thickness, and even sometimes RHA1 for very superficial fine lines that patients just want to polish off the final result if you've been treating in the deeper layers. So for me, the whole suite of products is perfectly applicable to the midface. And if we look at the bony changes that happen in this area, effectively the maxillary angle and the piriform angle reduce over time. And what this means practically is reduced projection, bony projection. So we have to consider replacing some of that bony support in the deep layer. And we will look at the orbit widens over time. We see a widening at the superior medial aspect and inferior lateral aspect. And then in terms of appreciating vascular dangers or key foramina, we really got to focus on the infraorbital frame when treating the anterior medial cheek, if it's indicated, because this is the emergence of the infraorbital artery and vein, and we have to appreciate this as a structure. And then in terms of deep fat aging, if you haven't already seen some of these videos, I really recommend as many of you as possible to go on the Untitled Digital Academy. You see some fantastic videos that talk about this in more detail. But for the purposes of this, in the mid-face, thinking about the deep fat, which again, remember, is a static fat compartment, we're thinking about the medial soothe, the lateral soothe, the deep medial cheek fat compartments, which atrophy, they reduce in volume over time. So not only are we thinking about replacing or reducing some degree of bony support, but replacing the volume in the deep fat compartments. And then we think about the superficial fat compartments. This is an area I believe that is often undertreated because we don't often understand how or what products we should be using. But with the RHA range, particularly RHA 3 and 2, we've got the products at our disposal that suit this area. And why they suit this area is because these compartments are a mobile compartment. We therefore want to place a product in these compartments that can move, i.e. stretch as the face animates to ensure we get natural outcomes. And if we look at the fat compartments, all of them, apart from the nasolabial fat compartment, atrophy. The nasolabial fat compartment actually becomes ptotic and enlarges. And we've got to be very careful about treating the superficial fat compartments that we don't place product in this fat compartment for fear of making the nasolabial fat compartment worse. And then finally, to finish off this talk, is knowing your superficial anatomy and landmarks. Understand the difference between the nasojugal groove, the palpebromalar groove, and understand also the mid-cheek furrow, because this I know is an important landmark, because in the mid-cheek furrow, it corresponds with the facial vein. And you can see here on the left-hand side of your screens, how the facial vein lies within this mid-face groove, and the facial artery lies a little bit more medial towards the nasolabial fold. So in summary, mid-face and temporal natural outcomes can be achieved as long as we understand the anatomy, we know which technique to use to deliver safe and effective outcomes, and we choose the right products. Thank you very much. And Melanie, back to you in the studio.
Thank you very much, Dr. Dillon, for this introduction, and we're looking forward to seeing now the application of what you've just explained. So let's move to you, Dr. Trepidic. I know you're ready. Up to you.
Thank you. First, we will have the slide of the patient just to show you. My first patient is a 38 years old patient. If we can have the slide of the patient on the screen. Just to explain what we will do. This patient has a lack of volume in the mid-cheek, and as you can see, she had previous injection in the tear trough. For that, the tear trough is nice and don't need anything, but she has a lack mainly in the mid-cheek and mainly in the anterior part. So if we go back to the patient here, the first question is where we can figure the deep and superficial fat compartments. And you can figure if you do only 3 lines on the face. So if I do 3 lines on the face of this patient, first, I will draw the line where I feel here the lateral wall of the orbit. And you draw a line, a vertical line here. That is what I call the vertical line of the face. So very easy to figure. Then you have to draw the mid-cheek groove. So it means you have here, as you can see on this patient, the mid-cheek groove. And the last line will be what I call the zygomatic line. That is the path of the zygomaticus major that is coming from the commissure to the lowest peak of the cheekbone. And if you do that, these 3 lines, you can figure the 3 deep fat compartments I will inflate with this woman. The first one here is what we call the lateral soothe, the medial soothe here, and at the cross of the 3 lines, you get the deep medial cheek fat compartment. So this will be inflated with my ultra deep. And if I figure above this, the superficial fat compartment, I will take a red one, you have here the infraorbital fat compartment here. You will have the medial one here and the middle one here. So you have 3 superficial fat compartments where I will inflate superficially with RHA4. So I erase my line, I put my gloves, and I will show you how I do my multi-layering technique. It means to fill the 2 layers of fat that disappear with your aging process. So I take my gloves and I first start with Ultra Deep. That is a product dedicated to the structure of the face. And I will put this deep, and I will put, because my syringe contains 1.2, and I will put half of the syringe on one side and half of the syringe on the other side. So I will put in each fat compartment 0.2 ml. So 0.2 here, 0.2 here, and 0.2 here. So I will start with my introduction needle. I will do my entrance point, and I will go here laterally to the lateral souf if you zoom on it. And I will go deep here on the bone at the superior border of the zygomatic bone. And then I will take, my syringe with Ultra Deep here, with a cannula, and I will start my injection, starting, this point, and go deep on the bone, sliding on the bone slowly. And to get the maneuver to lift and to be deep, it's very easy. You just have to take between your 2 fingers here, to pinch, to lift, and your cannula will be immediately deep. So my cannula, the tip of my cannula is there. So I will look at my syringe here. I will inflate 0.2 ml slowly in this area. So I don't put a lot. The patient don't want to be modified. And I will put 0.2 here. And that will be my first injection in the deep fat compartment, that is the medial souf. When I finish the medial souf, then I will withdraw my cannula and go to the lateral souf. So I withdraw, and I'm in the lateral souf, and I will inflate again 0.2. So I finish the 2 souf, and now you remember I have to go here, where it's my finger pad here of my index, and I will put again 0.2. So I reorientate my cannula. You see it's a non-painful injection. I follow the path of the muscle. I'm deep here, and I will inflate with 0.2 ml of product just here, where is my deep fat compartment. So here, if you look at my cannula and look at my syringe, and we zoom on the syringe, you will see that I use 0.6 ml of Ultra Deep. So I create the structure here. Then, because I will do the superficial one, you block it. So I will take the other cannula. So I take the other cannula, and I will use now RHA4. And each time I use RHA4, I will be in the superficial layers. And for that, I will introduce my cannula. And because I want to be very superficial, I will slide under the dermis. So I pull on the skin like this to slide under the dermis. As you can see, I'm superficial with RHA4. And I will do a fan technique in all this area just to inflate all this area with the fanning technique using, again, half of a syringe in this area, and I will mold at the end the structure, because my RHA4 is a product dedicated to the mobile area. So I'm doing my fanning technique, and I will stop at 0.6, and I will do it in the other side. just like I did on this side. Do you have any question?
There's just one question that came in, and this is, do you always inject ultra deep and RHA4 in the same session, or do you sometimes wait for a few days between these two procedures?
Sometimes you can wait for a few days, but if you make the plan to fill the two areas, this lady is 38 years old and she has a lack of volume mainly in the mid-cheek. I prefer to do it in the same time. And I finish, this area with my RHA4 dedicated to the superficial area. And I will inflate, all these layers here to get a nice and smooth contour to my patient. And now I will go on the other side. Do we have any other question here?
Well, not for the moment, so I will let you keep on with the demonstration, and as soon as I have something, I will tell you.
Okay, I will go on the other side. I will take again ultra deep. So I'm turning around, I'm turning the head of my patient. I'm doing my introduction point again, deep on the bone. And then I will use my cannula with ultra deep, and I will put my 0.6 ml of product deep on the bone to recreate the structure of my cheekbone. So I give that, and I'm going deep. You remember, if you want to be deep, you lift. So I pull up a little bit like this, and I push my cannula, and I'm sure that my cannula will be in the medial souf. You remember my medial souf is here. Where is the tip of my cannula? I will inject 0.2 here, withdrawing my cannula like this to create to inflate the medial and the lateral souf, and then going deep to the deep medial cheek fat, where is the finger pad of my index here, and I will finish with 0.6 ml of products in the deep medial cheek fat compartment. So I have finished with my ultra deep, and I will take the other cannula, but you can change your syringe if you prefer, and I will do the superficial plane. So I will introduce by the same point here, superficial, so I pull on the skin. I'm going very superficial, as you can see here, and I will inflate slowly in a fanning technique all the superficial fat compartments, pulling on the skin, as you can see, just to be very superficial, just to be in the superficial fat compartment, because my superficial fat compartment decrease as my deep fat compartment. Here I have finished my two layers. Deep fat first, with the product dedicated to the structure ultra deep, and then a product dedicated to the movement, the superficial fat, inflating the two areas. Then I will take the post-procedure cream, and I will mold the area of the face. And as you can see here, if the patient is going to be face, and you zoom a little bit on this patient face, you will see here that the face has recovered here a nice contour. I don't put a lot of product. It's not because you put two products that you put more. You put two products, but you put less product because you put the right product in the right fat compartment. You see no swelling, no bruising here. It's a very soft technique. You recreate the structure, but you feel also the superficial fat compartment.
Dr. Trevidic, we have questions coming in. You were using cannulas. What is the size of this cannula, and do you sometimes use needles for this multi-layering technique?
I use only cannulas because it's easier to do the two layers with a cannula. To do it with a needle, it will be only if I do a deep injection. And the cannula I use is a 25 gauge cannula, 40 to 50 millimeters length. It's the best cannula for me for this area.
And we have another question. Are you sometimes using other products in the superficial pass compartments?
Yes, sometimes when the skin layers are very thin, I use in that case RHA3 in the superficial layer, and I use deep RHA4, because if you use above thin layers, ultra deep, that is really a structured product that creates, you know, the deep layers, you can see a bump here, and you don't want to see two bumps. The patient, they don't like to have two balls here. So the way to avoid that when you have thin layers is to use RHA 3 and 4.
Patrick, it's Benji here.
Yeah, Benji.
Patrick, hi, how are you? Patrick, that was an absolutely beautiful result. We see an absolutely beautiful contour to the both cheeks, revolumization and improvement in the nasolabial folds. A question I often get when I'm teaching is about cannula use. You showcased a beautiful example of how to use a cannula so elegantly. Have you got any tips and tricks for people maybe looking to start using a cannula in the midface with these products?
Yes, the tip and tricks is sometimes what is difficult when you are a beginner. It's to be deep or to be superficial. And the little trick is when you want to be deep, you lift and you push. If you want to be superficial, you put your cannula deep under the dermis and you slide by pulling with your non-dominant hand the skin. Like this, your injection will be superficial. This is the only way to put products deep and superficial. And this is a little trick. It's just very easy. And I'm sure a lot of people are doing the same. Sometimes people use a lower point of injection. Why I use an upper point here is because here it's easy to find the bone on the zygomatic bone, on the upper border of the zygomatic bone. When you are here, it's not so easy to find the bone. You are very deep, and you are, like you said, Benji, in your beautiful introduction here, you are in the mid-cheek groove, and the risk is to touch here a little vessel when you introduce your cannula. So I prefer to do it at the top of this area than at the lower peak.
Beautiful. Thank you, Patrick.
So I have a question for you, Dr. Dillon, if you're still with us. What is your experience with TOCL products in multi-layer technique? What is your favorite product for treating the middle of the face?
So multi-layering should be what I like to say our bread and butter. It should be things we do when treating the mid-face. My favorite product and my most used product is RHA4. A lot of that is down to the fact that my demographic don't have a lot of subcutaneous fat. They and using ultra deep and all of them would lead to over projection. So, but when I am treating patients, I'll often consider in maybe a slightly slimmer patient RHA4 in the deep layers, as Patrick just mentioned, and often combining that either with RHA3 or RHA2 in the superficial plane. However, that said, we do get patients in with good subcutaneous fat, and I will not hesitate to use ultra deep in the deep plane, and then a product like 4 or 3 in the more superficial planes. But again, it goes back to the anatomy. We know we have 2 planes to treat, and it's often really, really considerate to get a good aesthetic result to use a multi-layering technique. And you know, Patrick showed a beautiful example of using a cannula to achieve this. There are some people that maybe choose to use a needle plus a cannula, but again, you know, using a cannula, how Patrick did, with very little risk of pain or bruises, is a beautiful technique.
Thank you very much for this answer. We have another question coming in for you, Dr. Dillon, and this is this a typical clinical situation in your daily practice? And what would have been your injection technique to treat this first patient in your clinic?
It's a great question. My preferred technique for treating the lateral cheek is, and I have done it historically, is a needle along the zygomatic arch, and then using a cannula anteromedially. So for example, I would do ultra deep with a needle along the arch and ultra deep with a cannula anteriorly, and then come with more superficial product with a cannula over the anterior medial cheek, plus or minus laterally. But you know, when you start to see people like Patrick inject so effortlessly with a cannula, you do mix and match. And what I would say is, although needles are my most preferred technique, I do use cannula exclusively in some patients. It comes down to the patient's anatomy. It comes down to what the patient expecting in terms of pain, discomfort, etc., and also the result you want to achieve. So I recommend everyone to be fully versed with both techniques so you can adapt it to the individual.
Perfect. Thank you very much. So we're going to move on now to our next live injection. We're ready with the next patient. Dr. Trevidic, up to you.
Thank you very much, Melanie. So we will see the picture of the next patient. She's 33 years old, and she had a lack in the mid-cheek, as you can see on her slide. She had a tear trough, but I will not treat the tear trough today. That is not by purpose. But I will treat the mid-cheek, and you will see that I will decrease the tear trough, and I will decrease also the nasolabial fold she started to get. And also because I will inflate the mid-cheek here, this will increase the depression in the temple. So for me, there is a circle of beauty coming from the tear trough, going to the mid-cheek, and at the end going to the temple. This is, for me, the circle of beauty we need to recreate. So for this patient, I will start up with the temple, and I will use my technique for that, and I will use what I call the deep technique, that is the gunshot technique. For that, you have to draw only also 3 lines. Here, this is the lateral wall of the orbit. This is the zygoma here. And at the top, you get here the temporal crest. And I look at my patient before, and I palpate here under my fingers the artery. And so my introduction point will not be where is my artery, where I feel my artery here. So I will do an introduction, if I turn the head like this, just here, where there is no arteries. Then you remember, I will draw 3 lines for my mid-cheek. The first line, if you zoom a little bit on it, you feel here the lateral orbit. And you remember, I will draw a vertical line here, very easy. Then I draw the mid-cheek groove. And the last line I will draw is the line of the zygomaticus major that is going from the commissure to the lowest peak of the cheekbone. So this is my last line. If I draw on it the deep fat compartments, we got 3. Here, it's what we call the medial souf, medial to this line. Then if I turn the head of my patient, you will see lateral to this line, the lateral souf. And here, at the cross of the 3 lines, you get the deep medial cheek fat compartment. So this is my 3 deep fat compartment I need to feel. Then I will put at the top above that, I will put the superficial fat compartment. We got 4 superficial fat compartments, but we will inflate only 3. Why? Because this one, that is the last one, inflating with the aging process. So I don't want to inflate here, but I want to inflate the 3 superficial one. And the first one, as you can see here, is the infra-orbital fat compartment. It's just above the 2 souf. Then you get 2 other one just below this first one, and there is here the medial superficial fat compartment, and the middle here. So I will do a deep technique for my 3 deep fat compartment and a superficial technique, fanning technique for that. So I will erase my drawing, I will do a disinfection, I will put my gloves, and I will show you how I do that, like I do in my office, very simple, and you will see at the previous patient the outcome, and I will show you one side done and not the other side to see the difference between the 2 sides. So I put my gloves and I will start with the deep gunshot technique in the temple with ultra deep, deep on the bone. And in this area, I will avoid the danger that is in the superficial layer. So I take my deep, ultra deep with my long needle, 25 gauge, and I will inject half of a syringe on this side. So how I do that, if you zoom a little bit here, I'm going, as you can see, where I put the cross, and I will go straight, and it's not painful until you touch the bone. Here I touch the bone and I slide a little bit to have all the bevel along the bone. And I will inflate slowly with 0.6 ml. So this is my favorite technique because it's a very safe one, very efficient, and very fast. So do you have any questions?
Yes, I do. We have a first question coming in, and this is there any risk of malar edema with superficial injections in this area with a cannula? And what are the main concerns with this layering technique?
When you have a swelling and edema in the malar area, it's a contraindication for superficial injection because your HA is going to bring waters here and to increase the swelling. So in that case, I will not inflate this area. This lady has no swelling here, but I will be very cautious and I will not put a lot of product in the superficial area. I will put more deep to create the structure, and I will after put a superficial one. So to do the other side, as you saw here, the other temple side, I will change my needle because I touch the bone, and so I need to change my needle because I erase the bevel of my needle. So I use a new needle here. I'm going on the other side, turn around my patients, and again, go deep here until I touch the bone. I slide a little bit bevel down, and I inject slowly to create no pain, 0.6 ml of products. It's not painful, but you have to inform your patient that during 2 days, when she will chew or eat, she will have, some little pain because the product is just behind the the temporalis muscle. I finish, I did the 2 sides, 1 syringe of ultra deep, and I will start the multi-layering technique. So I will do my entrance point. I will use ultra deep, and I start my introduction point here. You remember, deep on the bone. Here, I'm on the bone, touch the bone, and I will go with my cannula here of ultra deep, and I will put half of my syringe just to feel my 3 deep fat compartments. So a bolus here, and the last bolus will be here. So I introduce my cannula. So here it's my introduction point. Here I'm on the bone. You see, I touch the bone with my cannula. And you remember the maneuver. If you want to be deep, you lift the tissue. So you see, I lift the tissue and I push here my cannula, and I'm sure that my cannula will be deep on the bone. Here, I'm going to the medial soup first, and I will inflate with 0.2 ml of product. just to inflate this area here, where is the deep fat compartment. When I did this bolus here, I will withdraw my cannula, go in the lateral souff, do again 0.2 ml of products here in the lateral souff. Then I will go deep, reorientate my cannula, and going here in the deep medial cheek fat compartment. And I will inflate again with 0.2 ml. So in that case, I use for this patient 0.6 ml of products of ultra deep. Then I change my syringe and I will put RHA4. So RHA4 is here, and put RHA4 on my cannula. And then you remember, I have to do the intraorbital fat compartment here, the medial one, and the middle one. So I will go superficial. As you can see here, my cannula is superficial. I will put RHA4 slowly and doing a fanning technique in the superficial layers, filling all this area with 0.6 ml of RHA4 in the superficial layers, where it's a mobile area. And you see I'm going until I reach here. It's very easy to do it because you are in the superficial layers, and you will finish with a gentle massage of this area to mold this area. I will go on the other side here. So I take my cannula. Again, I take my needle here. Yes, thank you. And I will do it on the other side. Do you have any question?
I actually have a question for Dr. Dillon.
Yes.
What is your opinion in the treatment of this area? Do you use the same multi-layering technique for all ethnicity, and any different techniques depending on ethnicity or age of the patient?
When the patient is very young and still you have this lack of volume, the patient starts to get a deep fat compartment deficit. So in that case, I will use only ultra deep to fill the deep layers. And in that case, I will not do the superficial layer, because when you start to go in the aging process, you are losing first your deep fat compartment. So I always, when a patient is young, start to have a mid-cheek fold, I will use in that case only ultra deep, just to see if it is enough. And then in a second session, I will use, if it's not enough, a superficial injection with RHA4. So this is what I do in case of a young patient. In case of a man, I will inflate more the medial souff than the lateral souff, because male patients, you don't need to inflate too much the lateral souff, or you will get a feminization of the face. So here, I will inflate for a male patient more here in the middle than in the lateral point. And if you go to the Asian patient, you will inflate more also in the medial, in the deep medial cheek fat, than in the lateral souff, because we know that Asian patients, they need more volume in the middle of the face than in the lateral of the face, because their face are broader and their bone are more wide. So this is why we do a difference regarding the genders. Yes?
Okay, so actually we had a question for Dr. Dillon. Can we have your point of view on what Dr. Trevedic just discussed? Do you share this point of view, Dr. Dillon?
Absolutely. I completely agree with what Patrick just said. And I think the key is very much not the way you inject necessarily. I think it's the choice of product and the volume. So just like, Patrick just said, if we take Southeast Asian patients, for example, if they want to westernize their face, we're often going to be putting in a female face more product in the anterior medial plane, deep and superficial, to account for that flat maxilla, rather than laterally, whereas we may not necessarily be doing that in a westernized face. And then you've got to think about, women, if we talk about women specifically, from Africa, and we've got to think about how their faces adapt. So I think effectively, yes, anatomy changes in terms of where the volume sits or projection sits, but the techniques are effectively the same in terms of how you get there. It's how much volume and what product you use. If we're looking to replace bone and deep fat, give projection, ultra deep is a beautiful product to use, and a more superficial plane, a product like one of the RHA range, such as RHA4.
And we have another question actually for you, Dr. Dillon. What about the temples? How do you rate the need to treat the temples? And what is your favorite product for treating temples?
So in answer to the first question, how do I rate the need for treating the temples? I think past a certain age, based on the age-related changes we see, I think the temple is a very important and a key area to treat. What's interesting about the temples is I don't think it's an area most of our patients see when they walk into our clinics. They don't quite understand that this is an area that's an aging change. Often females may wear their hair low. So us as the doctors and the professionals should be advising on that. And in terms of products, most of my product usage in the temple is ultra deep, because if we're treating it, just like Patrick has shown, we're replacing volume loss, and there's no better product in my eyes than a product like ultra deep.
All right, thank you very much. Let's go back to you, Dr. Trevedic. So how is it now with the treatment?
I will let the patient tell you. Do you like this treatment?
Yes.
So you see she has a nice shape here. If we can go a little bit closer, you see that a great part of the tear trough disappear. All the lateral part of the tear trough disappear. If we can see the picture before the injection, you will see that this here, the tear trough here, disappear on the lateral side. And as you can see also, the nasolabial fold here disappear also because you inflate, all this area here. So you get a great circle here from the temple to the mid-cheek groove. And the last point I will have to do is to do a little bit in the tear trough with redensity 2. But this will be for the next step. This is not my purpose tonight. Thank you very much.
Patrick, may I make a few comments about your result, if that's okay? Some of the key things that stood out, again, a beautiful result. I think for the delegates and the viewers watching this, what's beautiful about what you just shown, I think most importantly, is how you avoided treating the superficial nasolabial fat compartment, and how you knew exactly where your cannula had to go to avoid product going into that compartment. Because I think that's often an area people miss and kind of get lost in and risk worsening the NLF. The other beautiful thing that you showed, which I think delegates should really take home, is how Dr. Trevedic showed these beautiful threads of superficial placement of product rather than allowing boluses of product. And then finally, you demonstrated excellently that the tear trough doesn't always need to be treated directly and can be treated indirectly by treating the midface, which again, I don't know if you want to maybe mark out the nasolabial fat compartment and how you identified that.
To identify, the nasolabial fat compartment that you don't need to inflate, if we go back to the patient, you have the mid-cheek groove here. So this is my mid-cheek groove. And you get here the nasolabial fold. And so between these two lines, you get here the nasolabial fat compartment that will first inflate and drop down. So this is why you have a nasolabial fold. So for me, the ultimate line, the lower line where I will never inject below, it's the mid-cheek groove. I will not inject below this mid-cheek groove because my patient deflate above and inflate under. So it's very rare you have to inject here because you will go against the aging process. This is the same with the jaw here. These are two fat compartments that increase with the aging process. Is it clear?
Beautiful. Thank you, Patrick. Absolutely.
I have a question for you, Dr. Dillon. Taking into account the difference between male and female, what is your opinion regarding the face contouring? What is the difference between your own technique?
So I think understanding gender differences is really, really important. In the female face, we want this beautiful, smooth transition from the lateral cheek into the anterior medial cheek. This means, yes, we want good projection in the lateral cheek, but we need some degree of fullness in the anterior medial cheek, and we want this to contour around beautifully so that when we do turn the patient at a 45 degrees, we get a nice, beautiful OG curve. Whereas in the male face, it's very different. The male cheekbone sits slightly lower than the female cheekbone, and the male face traditionally has a flatter anterior medial compartment. So they don't have necessarily a smooth compartment, so it highlights the male cheekbone. So in terms of differences, in terms of what we're trying to achieve in terms of technique, again, I don't think it necessarily changes our technique, whether we use the technique Patrick has just shown with the cannula entry at the top of the zygomatic arch and coming medially to treat the medial compartments and the lateral compartments, or using needle. I think it comes down to where we're placing that product along those fat compartments or those landmarks, and again, what product we're using. But again, Ultra Deep, a fantastic product for male faces, just as we treated in the deep compartment, Patrick showed in the deep compartments for his two models. Patrick, would you agree with that?
I fully agree with you, Benji. I agree that for male, you know, we have more and more male are coming, but they want less, a little bit less than women. And I fully agree with you that the injection needs for male to be more medial than lateral. We don't want to have this sexy point here on the lateral so for men patients.
Something to add, Dr. Dillon?
No, Patrick summarized it beautifully.
Okay, all right. So I still have a question for you, Dr. Trepedic. Several doctors are asking why you're not aspiring before injecting. And can you say a few words regarding complication?
Aspiration has always been a controversy for injection. First, when you have a cannula, you are safer, and we have now a lot of publication that a cannula is safer than a needle, but a cannula is not 100% safe first. My second point is that aspiration, as we know with the publication, is only positive in 33% of the cases. So it means that even if you are in a vessel with a needle, your aspiration test will be negative in 60% of the cases. This is a beautiful publication of Gianni von Longhem. And my last point is that for me, I prefer to know my anatomy, to know that I'm injecting in a safe area, or I prefer to talk about layers, so a safe layers, than to aspirate, to feel safe, and not to be safe. So if you aspirate, go on. Do what you think it's good for you, but don't feel 100% safe if you have no blood that is going backwards in your syringe. Be very careful. It's a false impression of safety, the aspiration.
Well, thank you very much, Dr. Trepedic, for answering this question. It was actually our last question for tonight. So let me a chance now to thank you, Dr. Trepedic, for these 2 live injections. And thank you, Dr. Dillon from London, for the explanation and the introduction of this session. We hope that you enjoyed this session. Of course, we will have a next one. The next Theoxane Academy Geneva live session will be in February. And if you want to get all the information about these sessions, it's very easy. You have to go on Instagram, as easy as that. And you have to follow the account Theoxane Pro, @Theoxane Pro. So we're looking forward to seeing you soon again. Thank you very much for watching. Thank you to our experts for being with us tonight. Stay safe and have a lovely evening. See you soon.
Bye. Thank you.